A great honor to be here in this innovative Congress. And I would like to thank Professor Philippatos and, of course, Professor Karamasis for the huge honor. And we're talking about calcified lesions who have a male of 65, risk factors, smoking, diabetes, hypertension, dyslipidemia, family history, and rheumatoid arthritis. He has everything, and he has dyspnea on M4, and there is a chest CT, and because he had elevated D-dimer measurements, the CTPA also, that has as a bystander finding the extensive coronary calcification. Then he went for an echocardiogram with ejection fraction of 50% with hypokinesis of apical anterior wall. And after that, everything was done in another hospital. He had this coronary angio, this diagnostic coronary angio, and you can see there is, when there is no contrast medium, you can see the calcium, a fair amount of calcium. There is something else at the proximity of the LAD, maybe an ulcer. I'm not sure we're going to discuss this after imaging. And they just stopped there, and that's good for the patient. They stopped there. They needed more evidence, and they did a stress echocardiography, and they found a biphasic response of the hypokinetic segments. And then he was referred, he denied any other intervention, and he was referred to our hospital. Normal creatinine and LDL elevated. Here is the pharmaceutical regime, and this is, and we go for a right radial approach with XB 30.5 and 7 friends. And we have this diagnostic, let's say diagnostic at the beginning of the intervention. You can appreciate the calcium. You can appreciate this peculiar finding at the beginning of the proximal part, very proximal part of the LAD, and you can see that the first obtuse marginal has a fair amount of disease, but nothing more. And then we proceed to imaging. Can we?
So we did an OCT.
We did an OCT.
Please change to the OCT screen, and Professor Guagliumi can describe what we are seeing.
So we have quite a tight stenosis. In fact, if you're going back 1 second, can you go back to the laptop and show the last angio during the acquisition?
I have this is playing. They have to switch the view.
Okay.
Okay.
Just the last one. When there is the acquisition of the OCT, you can see that the flow is not fully respected distally. So it means that the probe, the OCT catheter, is almost occlusive. So it means that you have a very tight stenosis. Then we are going back to the OCT laptop.
Can we switch to the view?
Okay. And here just a few seconds. Once again, the black one is representing the lumen, proximally from this side, distally from this side. And then here you have what we call the normal.
The reference.
If I'm clicking here, you can see the EL. This is the normal vessel. And then I'm moving inside. Here there is some deep calcification. So the calcium is very well demarcated. And it's very important to know if it is toward the lumen or deeply into the vessel, because we saw a lot of calcium apparently from the angio. Then we are moving quickly inside. Let's try to adjust a little bit the imaging to get the full lumen picture. Also in the two-dimensional view, I'm moving. Here you can see there is not too much calcium toward the lumen.
And here we have?
Here there is one protruding, that is a spiky protrusion. This one that you have at this point.
Nodular calcification, let's say.
With full shadowing. And that is, well, I would say not a very smoothing surface. Then we are moving B side.
Could we characterize that as a calcific nodule?
Well, so if you say calcified nodule number, there are two things. There is some calcific protrusion inside. You can see is very asymmetric. Very important is the remaining 3/4 of the vessels are plenty of pathology. You cannot see anymore the EL. You cannot see the media. Means that except this small segment, means that you have a huge of fibrotic and fibrolipidic plaque. Also because the signal is damping. When you are not seeing the EL, it means that you have a lot of lipid that they are attenuated. So here you have a mix of fibroateroma and then calcified, very small protrusion. Here you have something that I don't think is related to the balloon predial. This is a small rupture, possibly.
We haven't done any balloon.
Correct. And so you can see again some protrusion at this point. So this is really an example of mixed pathology. The ones are that, and then I move in here, and you can see that the EL is marginally located. So if you have an IVUS catheter, you have an incredible amount of plaque burden inside. You can see that here the vessel is remodeling because there is a huge of plaque inside. So, and here you have a bifurcation. Here is the typical imaging of bifurcation, the number 8, and this is the carina in between that is thick. So there was some calcification. Here you can see it was not really superficial, and there was this small protrusion in the calcification in the distal portion. And here, proximally, you can see much more calcium at this level, but the lumen is very wide. At this point, if we are going to see the lumen, we are talking about a 6 millimeter square, and you have 305 in terms of diameter. And then you can go back. Here we are approximate some other possible rupture plaque.
Yes.
So it's a mix of a stable plaque, advanced plaque.
We read that as an ulcer.
Okay. Correct. And that is going to explain also the next imaging you are going to see.
Yes.
Can you go ahead?
Should I go ahead or should have the theory part of with Dr.
Okay, we can have the presentation by Dr. Poulidakis about how to assess calcium with imaging. And as we're waiting, as we're waiting for Manos, maybe we can reflect on the images that we saw and discuss about which technique better to use for calcium modification, if calcium modification is needed or not. So maybe Julie, you want to